Good afternoon, everyone. Welcome to Cardiology 305. Today we're diving into a topic that sounds like a bad medical thriller, the flu that breaks your heart. Mechanism and epidemiology of influenza trigger cardiovascular events. Let's start because the flu isn't just about cough and fever, it can literally break hearts. By the end of this talk, you'll be able to understand the sneaky mechanism that link influenza to acute cardiovascular events, review the rock-solid epidemiological evidence and the tight temporal window of danger, describe the full spectrum, frequency, and scary outcomes of cardiac complications, outline smart diagnosis and management, including antiviral, evaluate why influenza vaccination is now a serious cardiovascular prevention tool, and recognize the special populations and troubling health disparities we still need to tackle. Sounds good? Let's jump in. Influenza doesn't just make you miserable, it's a master saboteur of the cardiovascular system. It works through four main villains: systemic inflammation, a prothrombotic state, direct viral invasion, and hemodynamic stress. These pathways don't work alone. They team up like a criminal syndicate to destabilize plaques, trigger thrombosis, and injure the myocardium. Today, we'll meet each one up close. First up, the inflammatory firestorm, influenza, triggers a massive release of pro-inflammation cytokines, IL-1, IL-6, IL-8, and TNF-alpha. These cytokines activate immune cells everywhere, both locally in the plaque and systematically. One of their favorite tricks, upregulating matrix metalloproteinase or MMPs. These enzymes chew away at the fibrous cap of atherosclerotic plaques, thinning in until, boom, plaque ruptures and type 1 myocardial infarction. It's like the flu is handing the plaque a demolition permit. Next, the prothrombotic milieu. The virus ramps up platelet activation, boosts tissue factor expression, impairs fibrinolysis, weakens endothelial anticoagulant function, and even recruits neutrophils, extracellular traps, NETs, that act like sticky webs promoting clot. At the same time, influenza can directly infect cardiomyocytes, pericardial tissue, and endothelial cells, causing myocarditis, pericarditis, and global myocardial depression, even in people with perfectly healthy hearts before the flu hit. Double trouble. Finally, the physiologic stress test from hell: fever, tachycardia, hypoxemia, sympathetic surge, and volume overload all hit at once. This dramatic worsens the myocardial oxygen supply demand mismatch, especially dangerous if you already have coronary artery disease or heart failure. The flu essentially turns your heart into an overworked engine running on low fuel during a heat wave. The timing is remarkable sharp. This isn't a vague association. In the landmark 1 study published in the New England Journal of Medicine in 2018, researchers found a six-fold increase in acute myocardial infarction admission in the first 7 days after laboratory confirmed influenza. Look at these numbers. Influenza B was even worse at 10.11, while influenza A came in at 5.17. A 2025 meta-analysis confirmed the peak incidence rate ratio hit 6.83 in the first 3 days. Ischemic stroke risk jumps 4.72-fold within 28 days, and elevated risk can linger up to 2 months. The flu doesn't waste time, it strikes fast. Zoom out to the population level, and the impact is staggering. In New York City, among adults 65 and older, every volatile increase in influenza activity in the prior 2 weeks was linked to 5.8 to 13.1% rise in myocardial infarction mortality. Beijing, every 10% increase in influenza activity translated to a risk ratio of 1.02 for overall cardiovascular mortality and 1.03 for ischemic stroke, adding up to 916 to 1640 excess cardiovascular death every year in older adults, accounting for 3 to 6% of all cardiovascular death. Seasonal flu isn't just respiratory season, it's a cardiovascular killer season too. So, what actually happens to patients? The spectrum is broad: acute heart failure, acute myocardial infarction, arrhythmia, myocarditis, pericarditis, stroke, stress cardiomyopathy, and even sudden cardiac death. In a meta-analysis of nearly 7,000 hospitalized influenza patients, almost 10% developed any cardiovascular complication. Heart failure led the pack at 17.5, followed by arrhythmias 6.1%, myocarditis at 2.6, acute MI at 2.2%, and stroke or TIA at 1.1%. In a large U.S. surveillance study of almost 90,000 adults, 11.7% had an acute cardiovascular event. The median age was 69, and the usual suspect, older age, smoking, prior cardiovascular disease, diabetes, and renal disease, were the biggest risk factors. When the flu and the cardiovascular event team up, outcomes get ugly fast. Patients with influenza and acute MI have 60% higher odds of dying in the hospital, odds ratio 1.6, and nearly 3 times the odds of multi-organ failure. Their hospital stay stretches to 8.8 days versus 5.5 days, and costs climb accordingly. The pool in the hospital mortality from cardiovascular events in flu patients sits at 1.38%. Even in severe myopericarditis cases, we see tamponade in 36% and cardiogenic shock in 64%, with 14.7% mortality overall, though thankfully most survivors recover without long-term problems. The flu doesn't just trigger the event, it makes everything worse. Diagnosis starts with a high index of suspicion, especially during flu season. Don't brush off chest pain or shortness of breath in a flu patient. Order cardiac biomarkers: troponin for injury, natriuretic peptide for heart failure. Get an EKG for ischemic changes or arrhythmia. Perform an echocardiography to assess function and look for effusion, and consider cardiac MRI if you suspect myocarditis. For confirming influenza itself, use PCR from respiratory specimens, and if the upper tract is negative but you're worried about lower tract disease, test lower. Antigen tests are just not sensitive enough in sick patients. Management: antiviral therapy, cornerstone. Prompt antiviral therapy is the cornerstone. Start early, within 48 hours is best, but never withhold it in hospitalized or critical ill patients, even if you're late. Oseltamivir at 75 milligrams orally twice daily for 5 days is the go-to, and you can extend the course in critically ill patients or those with persistent viral shedding. If the patient can't swallow, switch to intravenous peramivir. Valosavir is an option as a single dose for uncomplicated cases when symptoms are less than 48 hours old. Treat the virus aggressively, it buys the heart time. Management: cardiac specific care. For the heart itself, follow standard protocols. Acute MI gets antiplatelets, anticoagulation, statins, and revascularization when indicated. Heart failure exacerbation needs diuretics, vasodilators, and inotrope tailored for severity. Myocarditis is mostly supported, but in fulminant cases, mechanical support with BA ECMO can be life-saving. Arrhythmias are managed per usual guidelines, and most influenza-related conduction issues resolve on their own. Important warning: avoid routine corticosteroids. They increase mortality and secondary infections. Immunosuppression is reserved for biopsy proven myocarditis with negative vital PCR. Influenza vaccination is a strong cardiovascular preventive evidence. Now, for one of the most powerful prevention tools we have, the flu shot. A 2026 meta analysis of over 1.1 million patients shows significant reduction in all cause mortality, cardiovascular mortality, and myocardial infarction. A separate meta analysis of 6 randomized trials with over 9,000 patients found a 34% lower risk of major adverse cardiovascular events overall, and a striking 45% reduction in patients with recent acute coronary syndrome. The IAMI trial showed 28% drop in the composite of death, MI, or stent thrombosis when patients were vaccinated after acute MI. The number needed to vaccinate to prevent one major cardiovascular event is about 56, number that rivals statins. This isn't just respiratory protection anymore, it's cardiovascular protection. Vaccination guidelines and formulation. Major guidelines have taken notice. The ACC and the AHA give a Class 1 recommendation for annual influenza vaccination in patients with chronic coronary disease and acute coronary syndromes. For adults 65 and older, prefer the high-dose recombinant or adjuvant formulations because immune response wane with age. In heart failure, it is a Class 2A recommendation. The safety profile is excellent, mostly mild injection site reactions or brief flu-like symptoms. The risk for Guillain-Barré is tiny, roughly 1 to 2 cases per million doses. Bottom line, this vaccine is safe, effective, and now firmly part of cardiovascular care. Special population, pediatrics. In children, the pictures looks different. Cardiovascular complications are less common than in adults and tend toward myocarditis, 0.2 to 2.5%, pericarditis, and arrhythmias rather than coronary events. Influenza B is particularly linked to these issues in kids. Hospitalization rates vary but are highest in infants under 6 months. The American Academy of Pediatrics strongly recommend annual vaccination for all children 6 months and older, with extra emphasis on those who already have heart conditions. Protect the little hearts early. Immunocompromised patients, think transplant recipients, cancer patients, or anyone on a heavy immunosuppression, face higher stake. They suffer more severe disease, prolonged viral shedding, higher ICU admission rates, around 14%, and mortality near 10%. Presentations can be atypical. Fever might be absent. Vaccination is still crucial. Use inactivated vaccines, preferably high dose or adjuvanted. Live vaccines are off limits. Vaccinations cut hospitalization risk by about 32%. When they do get sick, start antiviral promptly and consider longer course of combinations if shedding persists. Unfortunately, we can ignore the disparities. Hospitalization rates are higher among Black Americans, 68.8 per 100,000, followed by American Indian, Alaskan Native, Hispanic, and white populations. Among young children, minority groups face 2 to 3-fold higher hospitalization risk and 3 to 4 higher death rate. Vaccination coverage lags significantly in Hispanic and Black adults compared to white and Asian adults. Medicaid patients rely more on emergency departments and receive fewer antivirals. Poverty, household crowding, and limited primary care access make everything worse. These are not just statistics, they are preventable inequities we must address. Key takeaway points. Let's wrap up with the big message. Influenza triggers cardiovascular events through inflammation, thrombosis, direct infection, and stress. The risk spikes dramatically in the first few days and fuels seasonal surges in heart attacks, heart failure admissions, and cardiovascular death. When complications occur, outcomes are markedly worse. Prompt antiviral combined with standard cardiac care saves lives. Influenza vaccination is now a proven guideline endorsed cardiovascular prevention strategy. And finally, we must tackle the disparities that leave some communities bearing a heavier burden. The flu shot isn't just for the lung, it's for the heart as well. Quick disclosure before we finish. This presentation is for teaching and education purpose only. It is not intended as a medical advice or a substitute for clinical guidelines. Always interpret this content in the context of current best practice and your individual patient situation. For those who want to dig deeper, all the data today come from high quality published studies. The full reference list is included in the slide, starting with landmark papers.